Great. Thanks so much, Dr. Kim. And thanks for asking me to do this presentation today. So yes, I'll be talking about radiation treatments for thymic tumors in the era of the ninth TNM staging system. Okay. I have no relevant disclosures. So just generally thinking about radiation therapy and thymic tumors, the main indications for radiation, the most common indication is postoperative radiation therapy to the thymic bed after surgery. But we do use radiation for other purposes, including for definitive management of unresectable thymic tumors, for palliation, if tumors are, say, invading into the spinal cord or causing pain. And then under investigation on a clinical trial at Memorial Sloan Kettering, uh, they're exploring hemithoracic pleural radiation to control pleural disease. For the purposes of today, I'm going to focus on postoperative radiation therapy simply because the ninth TNM staging system affects the port indications most significantly. Thinking and talking about the role indications and state-of-the-art treatment for port in thymic patients, we actually had two great webinars previously in this month of May, the Thymic Malignancy Awareness Month. And so I'm going to briefly go through a little bit of data about port, but I really wanted to focus on how the staging system changes how we view our recommendations and indications for port. But Dr. Simone gave a great talk on the indications and state-of-the-art treatment for port. And then Dr. Girard and Dr. Botticella also spoke about the role and indications of port, focusing on their radiorhythmic prospective study. And so for more details, I would encourage you to check out those webinars. Okay, so thinking about port, just to summarize a little bit and also focus on the data that I think is probably the most clean and relevant. The issue with port in thymic tumors is that pretty much all the data is based on retrospective studies, database studies. The prospective data is really limited, and we're waiting on these trials to accrue and show us results. But in the meantime, all we have is retrospective database studies to help guide us in terms of whether or not port is indicated in different situations. And all of the data is, and all of the information we have is based on the MASOCA staging system. So this is a study from the ITMIG database that was led by Dr. Rimner that importantly took all patients with completely resected stage 2 and 3 thymoma. So they all had R0 resections. And what the data showed was that patients with stage 2 thymoma, as well as stage 3, had improved overall survival. So not just disease control and disease-free survival, but actually overall survival when they received port compared to the patients who didn't receive port. So that's for thymoma. There's data on thymic carcinoma, but the issue with thymic carcinoma is that it's even more rare than thymoma. So we have a problem with our data just generally with thymic tumors because the disease is so rare, thymic carcinoma being particularly rare. But there's data from different databases indicating that with patients with stage 2 and stage 3 disease, radiation actually seems to have or patients with thymic carcinoma tend to have more of a benefit with radiation therapy based on some data from these 3 studies, likely because patients with thymic carcinoma have more aggressive disease, have higher rates of recurrence, so maybe that's why radiation seems to have impact thymic carcinoma patients a little bit more favorably. So what do we do with all this retrospective database studies? How do we interpret the data? We have to rely on guidelines and algorithms to help guide us as to what our recommendations should be for patients. And these are two examples of guidelines. These are the ESMO guidelines on the right here, and then this is a treatment algorithm adapted from ESMO and the Rhythmic Network. They're pretty similar. So looking at patients with thymoma here and then thymic carcinoma here. Um, Depending on the type of resection, so if it's an R0 resection, then depending on the Masaoka-Koga staging system, and then the histologic subtype can help direct whether or not postoperative radiation therapy should be recommended or not. Interestingly, for the thymic carcinoma patients, for R0 resection, even if it's stage one, the algorithms tend to point to favoring postoperative radiation. These stage one thymic carcinoma patients are fairly rare in the literature, so we don't have great data to guide us. But these guidelines seem to favor doing port for even stage one thymic carcinoma, whereas for thymoma completely resected stage one patients, we have prospective data that we don't do port for the thymoma stage one completely resected patients. But all the other data is, based on kind of trying to collect all the retrospective data out there. The NCCN guidelines for stage one, even if it's thymic carcinoma, indicate that patients should go on surveillance, whereas patients with stage 2 to 4 disease should consider postoperative radiation. So even within our guidelines, there's discrepancies as to whether or not we should recommend postoperative radiation therapy or not. But again, this whole time, all the data that I've talked about in the guidelines are based on the Masaoka-Koga staging system. So now with the TNM staging system, how do we interpret it and how do we decide what our recommendations are, how to approach a patient while we're trying to counsel them on the benefits of post-op radiation? We really need to rely on, well, we're hopeful that when the data comes out for these prospective studies, because at least radiorhythmic is also gathering the TNM staging, we'll be able to have a better understanding of, according to the TNM staging system, which patients benefit from port. So these three studies, so radiorhythmic and the two studies from China, are all taking patients with Masaoka stage 2 to 3 disease, randomizing them to port versus no port. So we look forward to this data, but it's going to be years before we have it. So what do we do in between? How do we advise patients on the role of port in the era of the 9th edition TNM staging system? To talk about the 9th edition, let's first go back to the 8th edition. Dr. Willman and Dr. Rimner put out this nice review paper trying to, in a way, translate the TNM staging system to the Masaoka staging system to help guide indications for port after an R0 resection. And so in terms of how to translate it, for patients with Masaoka stage 3 or higher disease, generally we think that port should be considered. So if we're looking at the stage, Masaoka stage 3 and higher, that would include our TNM stage 2 or higher patients, as well as patients with nodal disease, and some patients with pleural disease. Where we know we should not do port is for those Masaoka stage 1 patients that are completely resected. And so these are some patients with the 8th edition of the TNM staging system, the T1A patients. But where port is controversial is in these Masaoka stage 2 patients, and the stage 2 patients from the TNM staging system, these T1 patients fall into the Masaoka stage 1 as well as stage 2. So how do we approach patients with a T1 tumor in terms of radiation? It does require a multidisciplinary discussion. So talking to the pathologist and talking to the surgeon, understanding how easy the tumor was resected, and talking to the pathologist to get a sense of how invasive and how aggressive the tumor seemed. That can help frame whether or not port should be indicated or not. So now what do we do with the 9th edition? So the changes to the 9th edition Basically, these T1 patients were somewhat condensed and then divided into to T1 and T1A and T1B based on size. So the T1 patients include patients with or without encapsulation or directly invading the mediastinal fat or the mediastinal pleura. And then T1A is 5 centimeters or less. T1B is larger than 5 centimeters. The other change that happened with the ninth edition is that patients who were T3 due to lung or phrenic nerve involvement are now T2. So you can see that over here. Luckily, this change between the T2 and T3 doesn't necessarily change whether or not we recommend port. So if it's T2 or higher, still we would consider port for those patients. But where it does make it a little bit complicated is in these T1 patients and trying to understand which are the patients that we definitely don't need to do it in, which are the patients that are more controversial. The reason why the staging system changed was because size was shown to have an impact on recurrence. So patients who had larger tumors were more likely to recur compared to patients with smaller tumors. And historically, we haven't really thought about, well, we haven't uh, strongly thought about that from a radiation perspective. Maybe it was in the back of our mind when we're trying to think about like a controversial, patient. And, if it was a huge tumor, maybe that would tip us over the edge to say, okay, maybe we should do post-operative radiation or not. But now that sizing is in the staging system, it's going to be a good risk factor for us to assess in future studies and going back and trying to look retrospectively to see how size impacts recurrence rates with respect to port. And this is the data that basically helped to amend the staging system, indicating that patients with larger tumors had lower rates of recurrence-free survival. What do we do about thymic carcinoma now? So based on the MASOCA staging system and TNM staging system, we generally consider port for MASOCA stage 2 and higher. And it's unlikely to be recommended for patients with completely resected stage 1, depending on the guidelines that you're looking at. But now that there's a little bit more ambiguity with the T1 patients, it's a little harder to know when there's a T1 patient from the TNM staging system, whether they're going to fall into this MASOCA stage 1 versus stage 2, and that does impact whether or not we recommend port. So again, talking to the surgeon, talking to the pathologist, trying to get a sense of how aggressive it seems is important when trying to understand if a patient should be recommended for port or not. And here's an example of a patient I saw relatively recently where this issue came up. She's a 40-year-old female who presented with a low neck, high mediastinal mass, which you could see here on the coronals, on the sagittal, and then on the axial here. So it was resected, and there was some ambiguity initially with the diagnosis, but eventually determined to be a thymic carcinoma. And this is basically what the pathology report said. It was a squamous cell, the margins were clear. In the specimen, there was benign thymic tissue, benign thyroid tissue, and then a benign lymph node. The size was 3.5 centimeters, so for a thymic carcinoma, it was a T1A and 0. So, and it turned out to be, it was like the superior horn of the thymus that was involved. So I saw her to try to understand, should I consider port or no for this patient? And, based on just the pathology report, it's really hard for me to know, is this a patient that it would have fallen into like a MASOCA stage 1 or stage 2? So I talked to the pathologist, I talked to the surgeon, and it was removed really easily. There was no concern for any invasiveness in the pathology specimen. It seemed to be there was no capsule, there was no involvement of like mediastinal pleura. And so we thought, okay, this seemed potentially to be like a very easily resected small thymic carcinoma, ultimately recommended observation for her. Okay, so in conclusion, most of the data to guide the recommendations for port comes from prior studies that use the MASA-OCA staging system, and we rely on this data for guidelines and recommendations. But the TNM staging system needs to be considered when recommending port, as the risk factors that are specific to the TNM staging system predict for disease recurrence. And so future data and studies need to incorporate the details of this TNM staging system to better understand the impact of port. So we eagerly await the results of the prospective studies, which will hopefully guide us a bit further. And Dr. Andreas Rimner, radiation oncologist in Freiburg, Germany, and his team are working on this initiative to retrospectively restage MASOCA staging system patients to the TNM staging system to understand the impact of port by TNM staging. And Dr. Rimner, he's looking for cases. And so, if you're interested in participating, reach out to the ITMIG group and we can put you in touch with him to try to gather as many cases as we can to work on this project. And that's it.